I would like to turn the mic over to Dr. Aaron Baggish, who is a faculty member with us at the Football Players Health Study. Take it away.
Thank you, Paula. Welcome, everyone, on behalf of the Football Players Health Study and this amazing group of panelists that I have joining me today. It's really a pleasure to be able to share the next hour with you. I'm going to spend just a very few minutes talking about the overarching goal of the Football Players Health Study as a segue into this discussion that we're planning to have with you today. Next slide. So the Football Players Health Study at Harvard, now approaching its decade anniversary, is indeed the largest study of living former players. We have successfully engaged more than 4,000 men who have provided us with comprehensive survey data, many of whom have come back for follow-ups, and a number who have come into Boston to visit us to participate in clinical assessments. While we only have roughly a third of all the men that have played football since the development of the helmeted version of the sport, our representation is quite diverse as a function of age, race, and position. And one of the things I want to emphasize is that within the Football Players Health Study, our focus is about more than just the lifespan, which is how long you live. It's really about the health span, which is the number of years that men live after playing the game, free from disease, pain, or disability. And all of the work we do places a high emphasis on health equality, race, and issues of discrimination. An important way that we conduct our research is to involve members of your community. So former players and their partners play a big role in helping us identify priority issues and helping us understand how best to disseminate the findings from our work. Ultimately, our goal is to establish safe and effective interventions, things that we can do to reduce the impact of common forms of disease that affect former players. Next slide. I just want to make a quick comment about the way in which we handle data. Very early on in the study, we were able to secure a certificate of confidentiality from the National Institutes of Health, which makes it 100% certain that we have no ability to disclose any of the information that identifies any of our participants, even under a court order or subpoena, unless you as a participant provides us with permission. So this is a 100% safe venue. And indeed, our study is not part of any ongoing or past litigation, lawsuit, or settlement activity. So a completely scientifically driven endeavor. Next slide. To set the stage for tonight's discussion, just a few words about attention, memory, and concentration. I think one of the places to start that we can all agree on is that brain health is a real issue for all of us, whether you're young or old, have played the game of football or not. Our brains are arguably our most important organ, and this is really an important topic of discussion. Most of the brain health dialogue in the football space has been focused on chronic traumatic encephalopathy, affectionately known as CTE. And what I think you'll hear us talk about over and over tonight is that CTE is an important entity. We all agree that it's a piece of this puzzle of brain health, but it's not the entire landscape. There are many diseases, whether CTE is present or not, that have independent impacts on cognitive health and brain function, and many of these are likely treatable. So one of the overarching goals of tonight is to help us start developing a broader, more open-minded approach to brain health after an experience as a football athlete. And it's tonight that we take a deep dive into this important topic. So next is for me to introduce a man that needs no introduction, Mr. Eugene Robinson, who's been kind enough to present us with some perspectives on the issues we're talking about from the viewpoint of a former player. Eugene, thanks for being with us.
Thank you, guys. Thank you for having me. My name is Eugene Robinson. I played 16 years in the National Football League. I started in 1985. I ended in 2000. My tenure with 4 teams, the Seattle Seahawks for 11 years, 2 years with the Green Bay Packers, 2 years with Atlanta, and 1 year with Carolina. Currently, I do television and I do some radio stuff here down in the Carolinas. Let me start back because I've been involved in the NFL for a very long time as a rep. And I was a rep with the NFLPA since 1986 until I finished the season. And I can tell you, when you're done as a football player, one of the things that is most disheartening is that you think you have no more an advocate. You think that when your career is done, it's over. And all the stuff that you have taken, all the hits, the hurts, and all the stuff is your problem and your problem alone. And so when I first was approached to get involved with the football study, I was a little bit skeptical, to tell you the truth. I was like, oh, I'm not sure. Somebody just wants more information from me. Are they going to actually do anything? But when I found out that the Harvard football study was actually going to do some articulable work so that they could help me, and as I continue to age, whether that was dementia, sleep apnea, whether that was memory loss, whether that was ACL stuff, whether it's all the things that kind of plague football players once they're done. They were going to help. I jumped in. I was all in it. And when they started gathering all the data from these ex-football players, over 4,000 players, I found out that I was not the only one that was happy about the work that they were going to go ahead and do and what they were going to be able to provide. When you end the game of football, it's almost like a death in your family. It really is for the football player, because you've done it all your life since you were a kid. And since you've done it since you were a kid, and now you're told that you can't do it anymore, it's a shock. And now you have all these problems. Well, this is where the Harvard Football Study, they come in and they fill a gap in a niche that is most needed. And so from that, I'll do that. And then we'll just, as we go along in the study, as we go along in the seminar, this webinar, any questions that may come up, anything, I'll be more than happy to go ahead and to answer. But most football players feel like I do, and like I did, is that there's no advocate and no one's helping them out. And everybody's thinking about the current football players and not the players who played and paid the cost.
Eugene, thank you for setting the stage so eloquently for us. It's now my pleasure to turn over the role of moderating to Dr. Amy Perlman, who's been with us in the past. She's not only a superb clinician, urologist, but also a great moderator and a delightful person. So Amy, thanks for being with us, and it's all yours from now on.
Awesome. Thank you so much. Hi, folks. My name is Amy Perlman, and my role is to moderate today's webinar. As the moderator, my job is to keep us on time. This webinar will end within the hour at by 1:30 Eastern Time, to help introduce my esteemed panelists and to direct the pre-submitted and live questions to the appropriate panel members. In addition to being your moderator, as Dr. Bagish mentioned, I'm also a urologist in Miami, Florida, with expertise in quality of life concerns that affect everyday men. So most of my practice is actually focused on helping men optimize their sexual health and hormonal health. And more importantly, I'm on a mission to help educate men and the important people in their lives when it comes to male-specific health concerns. Now, because I have a lot of tools in my toolbox as a urologist, I can confidently say there isn't a single person that I can't help. And I can also confidently say, I'm going to speak on behalf of my colleagues on today, that there's not a single person they can't help either. So today is not about making the perfect decision for the rest of your lives. That's too overwhelming and that's too much to ask for anyone. But today is about making the next better decision. And in order for you to make that next better decision, we first have to understand the basics. So let's get started. I'm going to introduce my esteemed panelists here. So first we have Dr. Daneshvar, and he is a neurodegenerative specialist. Dr. Dan, I'm going to have each of our panelists briefly introduce themselves, what their expertise is, and how their area of expertise can affect memory, attention, and concentration.
Thank you, Dr. Perlman. Now, I'm a neurodegenerative disease specialist. I'm the chief of brain injury medicine at Harvard Medical School. And I think my area is a little most closely tied to memory, attention, and concentration, because when you think of neurodegenerative disease, you think of things like Alzheimer's disease, Lewy body disease, Parkinson's disease, and of course, as Dr. Bagish mentioned, CTE. Now, the link between individuals who get repeated hits to the head and problems later in life has really been well established for decades at this point, with these large community-based studies where we look at individuals with lots of head impact exposure, like professional athletes, and we find that these athletes have like 3 to 5 times higher rates of dementia. Now, the question is, what's causing that dementia? And that's where neurodegenerative disease specialists really need to step in. So for the past 16 years, I've been trying to better understand that. Now, when we're talking about repeated brain impacts and clinical symptoms, there's a lot of different things that could be related to those two. Certainly the one that's first and foremost in a lot of our minds, especially when we're working with former professional football players, is CTE. Now, CTE is a neurodegenerative disease that affects some of the neurons, the brain cells, and causes them to degrade progressively over time. But that's probably not the only thing that's related to head impacts and problems later in life. There are also other neuropathologies that may be related. So for decades, really 60, 70 years, people have posited that getting hit in the head, especially traumatic brain injuries, could lead to other problems like Alzheimer's disease, like Parkinson's disease, if you think about individuals like Muhammad Ali. But what's important when we're thinking about all of these neurodegenerative processes is that we don't know what's going on inside someone's head until after they pass away. And so when individuals are still alive, there are a lot of things we can do to fundamentally affect the pathology in their brain and the extent to which that pathology manifests clinically. Because ultimately, even if there are some issues going on in the brain, if we can affect how those brain issues relate to how people are actually clinically appearing, well, then we can potentially treat or even cure that person from having any signs of a real brain disease. And that's where the rest of my panelists will really be able to help us out here.
Awesome. Thank you so much for sharing. More questions to come. Dr. Bagish, you had mentioned that brain health is so critical. You're a heart health specialist, and you're also, I believe you're tuning in from Switzerland because you used the word tonight. So why don't you give us a little bit about your background and that connection between heart and brain health?
Yes, thanks, Amy. So I was at Harvard Medical School for 2 decades and recently made a move overseas to Lausanne, Switzerland, where I'm now a professor of medicine at the University of Lausanne and run a sports science institute here. My interest in heart health and football players predates any of the work at the Football Players Health Study. It's been a fascination of mine for a couple of decades. And what we've seen as we've studied football athletes is that they are, in general, more likely to develop high blood pressure early in life, and that high blood pressure changes the way their heart shape and function looks. And what also is clear as a cardiologist is that in the general population, one of the most common reasons why the brain starts to get dysfunctional as we age is because of unchecked high blood pressure. So a normal link there, we have an early life exposure that causes high blood pressure, and we have people that are worried about brain health later in life. And so one of the questions that I wrestle with and that our group wrestles with is how much of brain health is a function of simply unchecked high blood pressure among former players.
Thank you. Next up, we always try to separate mental health from body health or physical health, and perhaps they are all one and the same, but we have 2 mental health providers with us today. Dr. Thomas, would you like to go first?
Sure. Hi, everyone. My name is Morgan Thomas. I'm a clinical psychologist in private practice. I work in Jupiter, Florida. I mostly treat kids, teenagers, adults. My expertise is in diagnosis of mental health disorders and also assessment. I currently serve as an advisor on the Football Players Health Study, and I am also the wife of a retired NFL player. So when it comes to what I do in mental health, memory, attention, concentration, these are key factors that we would use in assessment to determine functioning and well-being for someone. And these are also symptoms that we would see a lot of times in different mental health disorders as well, whether that may be depression, anxiety, or something like ADHD. So when it comes to those 3 factors, these could be symptoms that we're looking at, or these could also be the cause or the start of someone developing a mental health disorder. So these are important facets that we would be discussing in therapy, regardless of whether someone was a football player or not. So these are very important aspects of overall health and play a very key role in mental health as well.
Absolutely. And what you mentioned there and what Dr. Bagish mentioned is what we're talking about today is relevant to every living being, and particularly athletes as well.
Absolutely.
Dr. Reese, you're up next.
Good afternoon. It's a pleasure to be with you all this afternoon. My name is Roy Reese. I'm a faculty member at Morehouse School of Medicine in the Department of Psychiatry with an affiliation with the Cardiovascular Research Institute led by Herman Taylor, one of the PIs on the Harvard study. I come to this having co-led a study that looked at the management of chronic pain in former players, where we implemented a group-based pain management study to promote psychological resilience in participants by training. Like I said, I'm a clinical psychologist. And so part of the patient census that I work with is I tend to specialize in working with men, but also work with a number of former and current NFL players here in the Atlanta area. One of the things that, as I build on Dr. Thomas's comments a little bit about how concentration and memory are implicated and mood disorders, but also I would have us think about the intersection between physical and mental health. That I feel like we do ourselves a disservice when we put them in silos where physical health is over here and mental health is over here. That oftentimes what we find is that one is driving the other. So that many of the people who come in to see me, when I ask about when they had their last physical, often they're not able to answer that question. We start getting lab work, we start to get some indication about what might be going on in the background that's driving some of the psychological concerns. And we oftentimes find that people with psychological concerns that they're presenting with have things happening with them physically that they're not aware of because, again, they haven't checked. And so I think we need to think about behavioral health as a form of primary care, and that we need to be asking questions of everybody, but in this case, former players when they go in to make sure that that intersection is being considered. Look forward to this discussion.
Awesome, thank you. Now, when it comes to sleep, I think we all know that sleep is important, but Dr. Criado, how important is sleep and what is that connection when it comes to cognitive function?
Hello, everyone. And Amy, sleep is everything. It's foundational, as we know. And you can talk about how bad your sleep is or what the dangers are. We all know for Reggie White, unfortunately, is a poster child for sleep apnea and NFL athletes. But the fact is that all the sleep problems that occur with head injuries, their symptoms, the downstream effects are very similar to other things like neurodegeneration. And there's, of course, direct correlations between sleep problems and neurodegeneration. But the cool thing is that sleep is modifiable, right? So it's our secret weapon. So I'm board certified in psychiatry and sleep medicine, and I practice integrative psychiatry. Whole body health is brain health, is mental health, and preventing that stuff as well. And also focus on my sleep strategies for elite athletes, teams, and organizations. So we can actually build systems, go beyond the individual athlete, go to the systems level, organizational and team level, in terms of guidelines that I wrote for the Australian Football League, for example. Or how do you train the people on the ground to screen our athletes or former athletes for major sleep problems? Because we may not think it's a problem, but if it's suboptimal, if it's less than ideal, you're going to have progressive neurodegeneration. Every cell in your body is going to age. We can talk about testosterone levels crashing, unhealthy weight gain, predisposition to diabetes, cholesterol issues, sudden death, heart attacks, strokes. All of that stuff is directly implicated when it comes to sleep apnea or suboptimal fragmented sleep. But as I said, it's modifiable. We need to know what to look for, how to look for it, and what our treatment options are. And then for the active players, what about using sleep as a performance enhancing tool, as a preventative tool for downstream effects? And if someone's had a head injury or an injury, how can we use sleep to maximize their recovery and shorten their disability time? So that's what I do. And as we'll discuss as we move on, you'll see how sleep is modifiable in each of these different domains. So there was a study that showed this week, I think, that there was one bacterium in the gut that's associated with Parkinson's disease, which is neurodegenerative. We know the gut produces 75% of your neurotransmitters. And if your gut is out of whack, then your brain isn't going to function right. You're not going to sleep right. So my goal is to make it as simple as possible for us to understand that it goes way beyond snoring or stopping breathing at night when it comes to sleep apnea. But the downstream effects, when it comes to maybe reducing your blood pressure medication or your diabetes insulin pump dosage, those things matter on your quality of life. We can increase the quality of your life and increase the health in your life, not just the years of your life struggling with symptoms and multiple medications.
Absolutely. You know, what I find really interesting about what I do on a daily basis as a urologist is I send a lot of my male patients to get tested for sleep apnea. because so many of the concerns that I see in my clinic, namely erectile dysfunction and low testosterone concerns, if I just treat those issues and I don't address their underlying sleep apnea, I'm putting a Band-Aid on a bullet wound. I am not addressing the underlying issue. So everything that we're talking about today, it is all related. And I don't think our message is for people to have to get tested for every single one. If you have like a watch and you open up the watch and you look at one of those rungs, we just want to move that first rung so that we can improve the next one and the next one. Okay. So what we know and what I love about what the Harvard football player study is doing is they're studying a lot of aspects of men's health, including sexual health and hormonal health. And what they found over the last few years is that concussions will put people at higher risk of hormone issues and erectile dysfunction. And like everyone else on this call, we have solutions to those problems. So before we get into those solutions, let's start at the basic level of how do we evaluate someone, and what are some of those tips that might say, maybe there's a problem here, let's talk to a healthcare provider about that. So Dr. Corrado, let's start with you. When is snoring just snoring, or when should it prompt a test for sleep apnea?
Right. So if you're not waking up refreshed, that's not normal. Bottom line. So we can dig in deeper then. You're not feeling refreshed? Is it because your spouse notices that you stop breathing at night, or do you snore? Snoring may be just snoring, but if you're not waking up refreshed despite adequate opportunity to sleep, I'd say get screened for sleep apnea. So there's different screening tools we have in sleep medicine. Some of those tools are not really designed for athletes or people who've recently retired as well, because some of those criteria are, okay, you have to be over 55 years of age. Your body mass index is supposed to be over 35. You have to have hypertension. Your neck has to be thicker than 16 inches. Not everyone falls into that group. So I would say, especially in the population of retired NFL players, the CDC study showing 52% of them have sleep apnea. This was in 94. Now we have even more sophisticated tools to determine that. I'd say have a very low threshold. Not waking up refreshed or feeling sleepy during the day, or snoring, or have a dry mouth when waking up, or morning headache, get screened. Maybe it's simple. Maybe it's sinusitis or snoring, and the only thing that's troubling is that your spouse doesn't like you anymore. But beyond that, get it diagnosed early, because sleep apnea is going to cause all those downstream effects. Every night that you're asleep without sleep apnea being adequately treated, you're putting inordinate strain on your cardiovascular system, your nervous system when it comes to waking up anxious or having a low threshold for tolerance emotionally, and cognitively. Basically, your lymphatic system drains toxins that build up during the night, and it only opens in your deep sleep. So if you have sleep apnea, your sleep is broken up, less deep sleep, more toxin buildup, brain fog, memory issues, and downstream effects associated directly with dementia.
So Dr. Bagish, Dr. Criado just mentioned that association between heart health and sleep apnea. Is this why some people pass away in their sleep from underlying sleep apnea?
Well, I can't speak, and I'll let Shane speak about why people die specifically from sleep apnea, but the link between sleep apnea and heart disease is well established. And we see this all the time. Patients come in with elevated blood pressure, they come in with congestive heart failure, they come in with coronary disease, and it may not be all attributable to sleep apnea, but a fair chunk of it is, which is why as cardiologists, we actually send a lot of people for sleep studies. It helps us improve the way people feel, and it helps us get people off medications, which is one of our goals. Like we like to do as much as we can for our patients with lifestyle modifications, and sleep habits are one of those important lifestyle modifications, and not to push medications on people.
Mm-hmm. So would you say that if someone is improving their lifestyle, meaning exercising, eating healthier, maybe dropping some weight, and they're still having issues with their blood pressure, or you find that you have to put someone on more and more medications for blood pressure, that could be a trigger to get them tested for sleep apnea?
Yeah, we would call that refractory hypertension or refractory blood pressure. So failure of someone to respond to typical treatments. And what that should trigger is a list in the doctor's head of other things they're not thinking of. And that's when it's important to take a brief sleep history. And if there's any question about sleep being an issue, to refer them to an expert like Shane and to get a sleep study done so that we can make a diagnosis or simply cross that off our list.
Mm-hmm. Dr. Dan, what would prompt someone like you in your field to think maybe this person might have sleep apnea, other than what Dr. Shane had mentioned?
Yeah, I think honestly, if anyone presents to my clinic with problems of early cognitive decline or problems with concerns with memory, attention, concentration, one of the very first things I do is ask them about sleep. And honestly, I have such a low threshold to refer for a sleep study for these athletes, because based on their size, based on their overall health history, they're at such high risk that I often refer to sleep studies, even if they don't have a lot of notable complaints, just because there might be something else going on, and most importantly, something that we can treat.
Mm-hmm.
Yeah, and isn't it also true that over 50% of those, even sometimes some studies show 75% of those with neurodegenerative disorders also have sleep apnea? It might be central, it might be obstructive sleep apnea. So then when you're in the process of healing their brains through supplements and exercise and other strategies, their brain cells are still dying every night because their brain, because it's degenerated, maybe certain parts of the brain that regulate sleep and breathing while you're asleep may not work properly. If that isn't addressed, then it's going to perhaps fast forward the progression of the dementia, right?
And you're absolutely right. And it's not only just that you might be causing damage to the brain tissue because of lack of oxygenation, but it could also be, as you noted, that glymphatic process, the ability of the brain to clear out toxic neurometabolites, toxic proteins. That happens largely at night. And so it's not just that brain cells might be dying from lack of oxygen. It might also be that brain cells might be getting worse damage because they're not getting the kind of restorative, regenerative ability that they get at night normally during sleep.
Absolutely. And the inflammation pathway, which is exacerbated, worsened with sleep deprivation or fragmented sleep.
Wow.
So Dr. Shea,
yeah, go ahead.
I'm sorry, Dr. Shea, do the new tools of how you deal with sleep apnea, does that allow now the football player, the oversized guy, I'm an offensive lineman, defensive lineman, will they be still using the CPAP machine or will they not? You mentioned Reggie White, he was my roommate, and he had that machine and he was using it all the time. So does the new technology, new tools, will that allow him to eliminate that process?
Yeah, Eugene, great question. And this is very relevant. It's very easy for a very lazy sleep doc to say, go for a test, you have sleep apnea, here's your CPAP machine, bye-bye. Maybe see you once a year, right? That's bad medicine. We need to know what the risk factors are. The most significant risk factor is obesity or excessive body fat. But then if you're not getting proper sleep quality, it's going to fast forward that, because as Amy could speak to the hormones, with less quality sleep, your testosterone levels drop, your growth hormone levels drop. So whatever you consume might be tailored toward fat growth, development and build up. Your hormones that make you hungrier go up. Your hormones that make you satisfied with your food go down. So for every 4 hours of sleep that you lose, your body thinks it needs 900 more calories to consume. And so weight gain is there. But yes, there are other tools besides the weight loss and CPAP, because it might be just positional. So you might just have really bad sleep apnea on your back because of gravity, 22 muscles between the tip of our nose and the base of our throat, the tongue falls back. So sleeping on your side anyway can reduce most people's sleep apnea severity. Maybe sleeping at an angle on your bed may be very helpful as well because of the effect of gravity. But then what else? There's also dental devices. So if someone cannot tolerate the CPAP machine or don't like it for some reason, a dental device is fitted by a sleep dentist, and they measure and maybe slowly use that device to extend the jaw by 1 millimeter or 2, but then get a sleep study after you start using it to make sure that it's adequately controlling that. The dental devices are great for mild and moderate sleep apnea, and then it depends on how you decide what's moderate and what's severe. So sleeping on your side, weight loss, CPAP, positioning, but also there's other strategies. Now, back in the day, in the 90s, they do a lot of surgeries, awful surgeries. They remove your part of your palate and your uvula and your tonsils. Very bad surgery, but the results weren't that great. So if someone tells you to go for a surgery as the first step, say no, get a second opinion. And now people are talking about another device, a stimulating device for the nerve that supplies the major muscle for the tongue. That device is called Inspire. And it's typically reserved for a very narrow group of people. So patients come to me and say, I want to get Inspire. Well, I'll inspire you with some facts over here. It's only effective in the 66% of people who meet very narrow criteria. They make you go under anesthesia, look at how your airway collapses to see if you're a good candidate. If you have mild or moderate sleep apnea and you're a good candidate, and they do the surgery, which costs like $40,000 to $80,000, depending on where you're getting it done, it's effective in only 66% of people. My job is to educate you in terms of how scary this condition is, but also what to do about it. Maybe some amount of weight loss can reduce the pressures in your machine so it's better tolerated. Maybe you could use a dental device and sleep on your side. Maybe sleep on your side and use the CPAP machine while working on your weight loss goals. So this combination strategy tends to serve us best.
Mr. Robinson, I'm so glad that you asked that question, because I think two major barriers to people getting tested is one, the actual test itself, having to go into a facility, which some people may be able to just do the test at home, and the fear of having to wear a CPAP machine. And so what we all heard from Dr. Criado is that there's not just one way to get tested, there's not just one symptom, and there are many treatment options.
Absolutely. And it might be just tonsils, right? In little kids, they may have adenoids or tonsils, and if those are removed, the sleep apnea resolves. So one size does not fit all, even if you're afraid of getting a CPAP machine as a Christmas present because you're afraid of the test. Don't be. Just get the test done. See a qualified doctor who can actually explain to you the nuance behind the results and then give you the best combination treatment strategy possible.
Awesome. So I want
So one
to
of the
go ahead,
things, yeah, sure. I'll be brief. One of the things I want to add here is the implications of sleep for mental health. The person who comes into you because of increased irritability, emotional dysregulation, they're having a hard time manage their responsibilities at work, etc. That one of the things that we know, I think Shane said, sleep is everything. I'm not inclined to disagree with you. That we know that quality sleep is an important predictor of positive mental hygiene. And so that what we're talking about, these physiological, blood pressure and the risk for cardiovascular disease as being real elements of sleep apnea, there are also some mental health implications that we need to be mindful of. And that oftentimes it will be that irritability, it will be that emotional dysregulation, having more conflict at work, at home with the kids, etc. That is the thing that says, hey, there's something going on here. Because a typical part of our assessment is, hey, tell me about your sleep. Are you getting adequate sleep? To your earlier point, are you waking up well rested? If not, why not? And let's figure it out. And so that becomes part of our checklist for how we also get folks to sleep doctors to kind of have that evaluated.
That's a really good segue into the communication piece. So Dr. Reese and Dr. Thomas, let's say a spouse notices that their partner is a little bit more irritable. What are some communication tools, phrases, words people might use to encourage that person to seek help if they notice some of these mood changes that encourage rather discourage them from seeking help?
Words and phrases. That's a good question. I think it's important to communicate in a supportive way, in a way of telling your partner or your family member what you're noticing, and then giving them the opportunity to reflect upon that and see if they're noticing or experiencing what they feel like you see. And I think when it comes to mental health and depression, specifically when it comes to sleep, right? It's so important to know what that can look like, and that can be insomnia, which a lot of people are familiar with that phrase, which is not being able to sleep at all. But then also hypersomnia, which is when someone is sleeping far too often, so 12 hours throughout the day. And a lot of times those are things that maybe we minimize or we don't talk about as much, but these could be indicators of things like depression or other types of sleep difficulties, such as sleep apnea or things that are beyond the scope of mental health. But just being able to, I think, recognize what would be significant and communicating in a way that is supportive and understanding, and with a lot of patience and understanding and empathy for family members, so that they're not feeling defensive, but supported.
Yep. What I would add to that is, I think that part of this conversation begins before we even have a problem. So, I encourage my patients to make sure they have a regular PCP that they're having, regular, at least annual contact with, because very often that's the place where those conversations have the best chance to happen. And we know for men that it's very important that they have a relationship with their primary care doc, because that's the person who they're more likely to be vulnerable with and talk about the kinds of things that they're being challenged with, so that when your partner then says, hey, are you good? Like you seem a little short, a little off, or whatever. I might not be ready to have that conversation with my spouse, but if I have a relationship with my primary care doc that says, hey, my wife said, or my partner said, I'm not sure what's going on, and they can then help you think through, hey, let's figure out what's happening here. I've got your labs, you're within normal limits on most of these things, so maybe there's something else. I'm going to have you talk to somebody else that can kind of help evaluate whether there's something going on around your mood and irritability and things like that. I think also making normal talking about health. I think a mistake that we often make is we talk about health when there's a problem. And I think, we have to talk about health just like we talk about finances, like we talk about the kids, et cetera. And when it becomes a regular part of what we do, then it normalizes the conversation. So then I'm not, to Dr. Thomas's point, I don't get defensive when you say something to me about being short with the kids. I'm like, because we talk about this on a regular basis, and I've been prepared to receive feedback, but as also give feedback. I think the thing that where we take some pressure off spouses is when we think about our peer groups. Is health something that we're talking about? Are men talking about health? One of the things that we learned in our study was that men are often isolated, and it's only when they come together in groups, such as the group that we ran, or the guys that they work out with, or the guys they might meet out for a beer, something like that, where the opportunity to talk about some of these topics is a very real thing. But are we planting the seeds where that's being talked about? Are they talking about men's health in your church, in your barbershop, so that, again, it doesn't become an outlier thing, so that when we talk about it, we do get defensive, but it becomes something that's been normalized and that we almost invite it. So we have to create safe spaces for men to talk about health, and also to receive feedback about their both physical and mental health.
Mm-hmm. Now, based on what Dr. Corrado was saying, I would venture to state that most people should probably get tested for sleep apnea. So would it also be true that most people should also see a mental health provider? Do they need to have a problem with depression or anxiety, or can it be helpful just to sit down with someone on a regular basis to simply talk?
I don't think there needs to be a problem whatsoever. A lot of times what we process in therapy are positive and good emotions. Everything in therapy is not about dysfunction or distress. And I think that's a huge stigma. People think if you're going, or if you're interested in going, that something must be wrong with you. And a lot of times there are things wrong with us, but feelings are fickle, things come and go, and it's important to be able to process positivity in life in the same way that it's important to process difficult emotions and distress when we do have it, because really it's good practice. If you're able to communicate and open up about the way that you feel, even when it's good, you're more likely to be able to do so when it's not so good. And something that I wish existed a little bit more was like the mental health presence in primary care. It's there to a certain extent, but if it was emphasized more, I think that we could catch things and have better preventative care, so that people aren't always showing up to myself or Dr. Reese when there's a crisis, or when a trauma has occurred. So I think people should see it from a more normalized perspective, that mental health is just like dental health or heart health or anything else. We're just speaking about the brain, and we're speaking about emotional health. And hopefully the more we continue that conversation, the more comfortable people will get with seeing it as something that is as regular as going to the dentist or any other type of clinician or physician.
I
That's
love that message. Go ahead.
Brad.
Dr.
Also
Yeah,
about
so
Oh, sorry.
go Shane.
it's also about the integrative approach, right? So as a sports psychiatrist, we don't just focus on something when there's a problem. We want to preempt it, but look at all the contributing factors. For example, depression might be low testosterone, it might be sleep apnea, it might be low iron because iron is needed to make dopamine in the brain, it might be low zinc, might be any of those things, including mold toxicity and inflammation. And if we can mitigate those, then maybe someone doesn't have to be on a medication if we correct those underlying factors. So there's a preventative role, but also an optimization role for us as providers who work with athletes, not just years of medicine, years of CPAP machine.
Awesome. Dr. Reese.
Yeah, what I would want to add is I think this has to be a tiered conversation. And so one of the things I want to push out is how we practice positive mental hygiene. Are we getting enough sleep? Or do we have a healthy diet? Are we physically active? Do we effectively manage our stress? Do we have positive peer relationships, family relationships, things like that? Because the practical reality is there are not enough behavioral health providers to see the volumes of people who are out there. Almost all of us have waiting lists that are extensive. And, my approach is I wouldn't refer somebody to see anybody that I wouldn't refer a family member to. And so that number then even gets even smaller. So I think if we promote practicing positive mental hygiene, and then if we have a primary care doc who we see on a regular basis, and the screening and checking in around behavioral health, mental health considerations is a part of that, I think it makes good sense to have 2 or 3 folks that if you had to see somebody that, hey, this is the person that I would want to see, or be able to kind of get on that person's wait list. And I think if we take that tiered approach, we have the opportunity to do some really good preventative work that keeps you off the virtual or the literal couch. And then I think that when there's a need to activate that resource, we know where to go, right? And so, for example, a question for a PCP is, if I needed to see a psychologist or psychiatrist, who would you refer me to? Like who are the people, and do they work with men? Do they work with former athletes? Like what's their specialty area? Because sometimes the providers need your feedback about kind of who should be in their referral base when they think about referring out. So those would be some of the kinds of things I would have us think about.
Mm-hmm. So I want to transition the conversation now, both again with Dr. Reese and Dr. Thomas, to talk about the impact of anxiety and depression on cognitive function. And then after you discuss that, I want to go to Mr. Robinson to talk about, as you get older, as a former NFL player, as you get older and you start to notice changes in your cognitive function, what are some of the concerns that come to mind? And then I want to go to Dr. Dan for, how does that conversation come about? When should someone see someone like you when they're noticing changes in cognitive function? So Dr. Reese and Dr. Thomas.
Sure. So a part of diagnostic criteria for both anxiety and depression, we're looking at cognitive function. How well are you thinking? Are your thoughts rational? Are they declining? So not only are these symptoms and things that we would assess, but they can also be causes or things that we would look at and say, okay, we're noticing this. Maybe this is anxiety. Maybe this is depression. So there is 100% a direct link in cognitive function when it comes to both anxiety and depression. And there is a variety of different presentations and how that can look in treatment.
Yeah, I think, so this goes to the assessment question in the breadth. So if I'm only looking at anxiety and depression, am I missing something? So for example, the person who's a type 2 diabetic, but who was not medically regulated, for example, that person is more likely to experience a mood disorder, experience impacts in concentration and memory. And so that's where that interface of looking at kind of what's going on with the patient physically, as well as what's going on with their behavior or their mental health, becomes really important. I think also, like, can we identify stressors within the person's life that might have activated, because not all anxiety or depression rises to a clinical level, even if that's the thing that kind of gets you in the door. So what are the things that are going on that can be modified by either lifestyle management, but also modified if the family knows more of what's going on, or if you refer the person to kind of work with the human resource department to kind of be able to manage some of the things that are happening at work some. So I think the nuanced approach, like you don't come into my office and I assume that I'm going to both be able to assess and diagnose and treat the problem, because I might need partners in that assessment, and that treatment process becomes important to how we get there. But I think, you know, challenges in memory and concentration it's a red flag that something is going on. Now, whether that's, you know, psychological or psychiatric or physiological, that's the question or the answer to be determined. But I think if we get them in to see somebody who asks smart questions that allows us, like, you know what, I think we're talking about, this really isn't a sleep issue. This is really a psychological issue. No, this really isn't a psychological issue. This is a cardiovascular issue. Figuring out where we need to be to get the help that's going to help reduce the symptom presentation and improve health is important.
Yeah, it's very much a two-way street, and you know, there's a well documented process that every medical student learns in medical school called pseudo dementia, and that is a presentation where someone looks like they have dementia, they have cognitive problems, problems with thinking, problems with memory, and it's the underlying reason for their cognitive impairment is actually related to depression. And it's so common, again, and it's so well documented that it has this name, pseudodementia. And we find that when we treat these individuals' depression, that dementia picture goes away. And so that's why it's so important. And I think I hope that the message here that we're getting from all the docs in this great panel is that these issues, whenever you're talking about cognitive impairment, there are multimodal integrated responses to the management of these individuals. And we really need to look at how they're functioning overall to make sure we're treating everything.
Thank you. Mr. Robinson, I want to go over to you. Is this a concern of yours from people that you've spoken to as you get older?
Absolutely. First of all, let me just thank all the doctors. Incredible discussion, and just rich with so much information. Thank you for that. My wife noticed my cognition declining, and she would tell me, you know, you forgot to do this, and you forgot to do that. And then I would like fight her, like, no, I didn't. What are you talking about? And then I finally started to listen to her, that I was having some decline. I was forgetting things. And so I had to do things like, if somebody told me something, I would write it down in the text so that I could look back through the text and see what someone told me. So I never erased my text, so that I could actually physically look through and see, what did I forget? And I found out I was forgetting a lot of information. Now I have another tool to do with that. My wife's helping me just writing information on a text or email something so I can look back at it. But that's a lot of players, and a lot of players sometimes feel embarrassed, all right, because they've been the big guy, they've been it the whole thing, and right now they are not it. And when you're not it, you're relegated to something else. And so from that standpoint, the decline of memory is huge. Whether we talk about that dementia, is huge because we think it's exacerbated because we played football, because we've been concussed, because we hit people every day. So when we look at our future, we see our future is not as bright, and we see there's not as much longevity in it because we've had things that we've been doing, which is bumping heads all day long. And so we understand this decline. I hope I have a long life to live, but that may not be the case. And that's where you guys come in to play, because you're able to help someone like me and other players along to go and to enjoy your life, so you can do and remember things. And that's been my experience with me and my wife, of me forgetting things.
Mm-hmm. Thank you for sharing. So you mentioned how your wife is helpful, how you, with intent, will write things down. Several panelists discuss lifestyle changes. I want to get a little bit more granular with lifestyle changes, because those are things people can start implementing today. So we have like 3 minutes left. I want people to bring up those lifestyle changes and touch on the impact of drugs and alcohol in this discussion as well. And maybe answer the question, are there any redeeming qualities to alcohol? What's the impact on cognitive function?
Well, I don't drink, so I'm pretty good on that one. I don't drink and I don't smoke, but you're right. My cognition, I write things down, and I don't get offense of people who say you forgot something. I don't take it personally. I take it like, hey, you're just trying to help me.
Awesome. Other thoughts from the group? What are things people can start doing today?
I think for family members and people who are close to the athletes, just noticing, being aware, paying attention, being supportive, maybe scheduling appointments for your spouse or for your family member on their behalf, going with them. A lot of times, like Eugene mentioned, the family members are the better historians. Sometimes we're able to provide historical data and context to clinicians that the actual patient may not be able to, and it may be life-changing information. So kind of just empowering family members and those who are around to use their voice, and not be afraid to speak up, even if it feels a little bit scary. Just make sure you're coming from, a place, of care and concern, and use your voice, because a lot of times it could be life-changing for the patient.
Dr. Baggett, you
think-
mentioned the importance of physical activity and brain health.
It can't be overstated, right? 30 minutes of moderate intensity physical activity every day. I look around this panel, I see a brain expert, I see a sleep expert, I see mental health experts. Every single one of the problems we've been talking about are benefited by routine physical activity. It's free, it's safe, it's easy. There's no reason not to do it.
If there was a pill that worked as good as exercise for Parkinson's disease, it would be $1 billion pill. If it, the same, the data shows the same for Alzheimer's disease. There's no reason that it wouldn't work for other neuropathologies as well. But on top of that, I think managing easy things, pain, headaches, cardiovascular dysfunction, diabetes, something that most people don't necessarily think about are things like improving your social network. So having more in-person engaging interactions with other people. Those kinds of things have been shown to benefit brain health.
What about when it comes to nutrition? We've mentioned the impact of inflammation. Are there certain superfoods that are good, or certain foods that we should stay away from?
There's a diet that's based off of the Mediterranean diet called the MIND diet. So it's the Mediterranean Inflammatory Neurodegenerative Disease. It's an acronym for MIND. But it's basically the Mediterranean diet, which is a diet that's low in inflammatory foods. So it's things like legumes, things that instead of red meat, more fish-based diet. Those kinds of that diet. So if you look up the Mediterranean diet, that's something that has been studied extensively in multiple different neurodegenerative diseases. And while the data is not 100% slam dunk one way or the other, it does look like it helps.
And also I'd add that antioxidants, vitamin C, astaxanthin, omega-3 fatty acids, more than 3,000 milligrams of EPA plus DHA per day, according to studies. Resveratrol, NAD, those ones are really powerful anti-inflammatory, but also antioxidant. And, speaking about sleep, timing, quality, and duration. 7.5 hours for most people who are not active athletes. If you're waking up unrefreshed, get a sleep study done, and fix timings every morning, and lock in your sleep with winding down before bed, getting some sunlight on your face for 20 minutes, not staring at it, but on your face for 20 minutes or so each day to consolidate your sleep rhythms. Those would be the most effective strategies in closing.
Awesome. One more question here. Someone had asked about CBD. Anyone recommending CBD for sleep?
I don't support CBD for sleep. CBDA has been shown to be beneficial, more affinity for serotonin receptors, reducing inflammation, endocannabinoid pathways, yes. But, I'm still on the fence about that. I need some more data right now.
Awesome. And then when it comes to sexual health and hormone health, everything you all have said also pertains to sexual health and hormone health. So food and exercise are the foundation. Anything that improves blood flow and reduces inflammation is good for brain health, heart health, gut health, and genital health. That's the beauty of it. It's all the same recommendation. All right. Any last thoughts, Mr. Robinson?
No, I'm just fascinated. There's a wealth of information, a wealth of knowledge. And I just want to encourage my players and my alumni to make sure that you grab hold of all the information. I heard that you need some sleep. I heard you need a good network. I heard you need to go ahead and be networking, that you can remember things. If you need help, ask for help. It's okay. And so I heard a lot of things today. And I hope we can put this like in a capsule that we can give this back out so that the people on this could have that kind of condensed form where they know what to do. Thank you.
Amy, if I could just quickly make one last point to follow up on something Dr. Reese has said a few times. Look, I'm all for more sleep studies, more contact with subspecialists in cardiology and mental health and neurodegenerative disease, but there's an upstream part of this, and that is maximizing your time with your primary care doctor.
Yeah.
Many people think it's about just showing up and going, but it's actually something that if you prepare for and you have a toolkit in your back pocket to make the best use of that time, you'll get a lot further with that. As a precursor, we're actually developing a tool that we hope to disseminate to the entire former player committee about just how to prepare for that PCP visit, how to choose the right doctor, how to ask the right questions, and how to advocate for yourself. So while we as specialists are very important, I want to be clear that I think that this all runs through the PCP, and former players can really make a dent in how that works for them.
Great. Well, thank you, Aaron, for setting that up. I'll just pull my slides back up here. So as Dr. Bagish just mentioned, we have been working on developing a checklist for former players and their medical providers, but this would also be relevant to family members and partners and spouses. And this is really a very accessible checklist of things to ask your primary care physician when you see them, so that you can really maximize your visit and look at some of the things that we're finding are affecting former players, sometimes more than the general population. So this will be coming to you in an email after this webinar in the next few weeks, along with some other resources. I do just want to share, we are in the process of sort of having these webinars be part of a series. So as a preview for our next webinar, which will be in February, we will be talking really about blood pressure and hypertension. We've been developing a campaign of knowing your over and under, which refers to the two numbers that are used in a blood pressure measure. So you'll be receiving this graphic, which will also be a card, but this is something that we'll be discussing really heavily in January and February, especially as February is Heart Health Month. So please stay in touch. The best way to stay in touch if you are a former player or a partner spouse of a player is to join our mailing list, which you can find on our website. I'll also be emailing this out. But you can also follow us on social media for research updates and event announcements. Our handle on every platform is Players Study. So very easy to remember. And in your email after this, you will also be receiving a post-event survey that we would very much appreciate if you'll fill it out. It helps us figure out what questions we really need to be looking more at, what sorts of webinars we should be having in the future. It helps us best serve the community. And finally, this webinar was recorded. We will be processing it to add captions to make it more digitally accessible. And then we will be emailing it out to you in the coming weeks as well. So lots of things to stay tuned for. And yeah, just wanted to thank all of our wonderful panelists, all of our attendees, and have a great rest of your Wednesday.